We'll start the sessions. It is said that skill once learned is learned forever, and when we learn it with it in the right way, and practice that makes it perfect. So today we have an array of routine procedures performed in our daily OP and OT, which is shown as short videos, and I hope all of you it will be useful for all of you present over here. So the first talk, we'll go straight away go into the first talk. It is tear function test by Dr. Gargi Sadish from Government Medical College, Kottayam.
Okay. Good afternoon, everyone. Going straight to thank you so much, Team Malapura and KSOS for this opportunity. So the tear function test, what are the essential skills and toolkits easily available? Now, from being a very simple disease, dry eye has evolved into a multifactorial disease with multiple dimensions. But do remember the two basic classification into aqueous deficient and evaporative dry eye. So one of the easiest tools available could be the questionnaires. Lots of questionnaires are there. The OSDI or the Ocular Surface Disease Index is a favorite one. We can translate it into the local language, and the advantage is that the patient can fill it even before we see the patient, so it can be a very useful starting point. So we get a score and we can start from there. Now, a tailor-made history probing into these details, which could be actually the cause of the dry eye in that patient, will be very, very helpful. Similarly, the clinical assessment should be focused on areas causing or related to dry eye, like the meibomian gland and secretions, the lid margin, the tear meniscus, etc., which will again help us in our diagnosis. Now, coming to the age-old test of Schirmer, which every one of us knows, lots of controversies regarding its reliability are there, but definitely it is a useful test to assess the quantity of tear secretion. So especially, after washing hands, the Schirmer strips, the filter paper is now easily available in the 35 millimeter length, has to be labeled right and left, and the 5 millimeter is bent. There should be a good patient communication because it is quite an uncomfortable test and it does last for around 5 minutes. So without touching the cornea or due touching the conjunctiva, it has to be inserted between the lateral 1/3 and medial 2/3. Patient has to be very comfortably seated with the head resting. The patient can open or close. The recent consensus is the patient can gently close his eyes for 5 minutes without the air condition or the fan, that you all should remember. And the amount of wetting noted, it can be done with or without anesthesia, Schirmer 1 and Schirmer 2 with nasal stimulation. Whatever it is, if the Schirmer is positive, or rather if there is dry less than 10 millimeters, that is very significant, and less than 5 definitely indicates dry eye. Suppose, and it has to be marked, and you can stick it on the patient file for future reference also. High false negativity is the main problem with Schirmer because of tearing when you are inserting the strip. Similarly, the next easy tool is the T-butt. We think it's difficult but very easy to perform. So you have to use a preservative-free solution like saline to wet the strip, instill it, ask the patient to blink, shake off excessive fluorescence, put the cobalt blue. After a blink, you just time it and look out for the dry spot. Should not be a fixed dry spot, you all know that. So I don't know whether it's clear, but the first dry spot appeared around here at around 10 seconds. So less than 10 seconds indicates tear film instability. So it is actually quite easy to do, and the pattern of the breakup also gives an idea to what sort of a dry eye it is. Similarly, we have already put fluorescent, so after 1 to 2 minutes, just take some time to note the fluorescent staining pattern, which could also give you an idea of what type, is it evaporative or aqueous deficient. So many sophisticated instruments are there now, osmometer, etc. But these valuable easy tools like a questionnaire, Schirmer, T-butt and fluorescent staining definitely leads us on to our diagnosis and we should treat the cause and not just the symptom of any dry eye. Thank you so much.
We can have the discussion at the end of the session. Next speaker is Dr. Mini PA. She will be talking on calibration of applanation tonometer. It is very important to calibrate the tonometer before using it. Over to Mini.
Good afternoon. An accurate measurement of intraocular pressure is important in the management of glaucoma. So, even though various tonometers are available for measurement of intraocular pressure, Goldmann applanation tonometer is the gold standard and is the most widely used one. To get an accurate measurement with this tonometer, it is important to check the calibration error of the instrument periodically. So let us see how to check the calibration error of Goldmann applanation tonometer. Let us see how to check the calibration error for Goldmann applanation tonometer. First of all, mount the applanation tonometer on the slit lamp. The calibration error checking should be done at dial positions 0, 2 and 6. To check the calibration error at position 0, we have to rotate the knob to position 0. Now turn the knob a little forwards, that is about 0.5 millimeters of mercury forwards, and we can see a forward movement of the feeler arm with the tonometer head. And now if we turn the knob backwards a little, that is about 0.5 millimeters of mercury, we can see a backward movement of the feeler arm and the tonometer head. To check the calibration error at position 2 and 6, we need a calibration error check weight bar, which is provided by the manufacturer along with the tonometer. This weight bar has 5 markings on it. The central marking corresponds to 0 millimeters of mercury, 2 markings on either side corresponding to 20 millimeters of mercury, and 2 outermost markings correspond to 60 millimeters of mercury. There is a adjustable weight holder to insert this weight bar. So we can insert the weight bar into the weight holder and insert the weight holder onto the slot provided on the side of the tonometer. Now adjust the weight bar in such a way that the marking corresponding to 20 millimeters of mercury should come in line with the index marking on the adjustable holder. Turn the knob to position 2 and now rotate the knob a little forwards, about 0.5 millimeters of mercury, and we can see a forward movement of the feeler arm and the tonometer head. And now rotate the knob a little backwards and we can see a backward movement of the feeler arm with the tonometer head. And to check calibration error at position 6, we have to adjust the weight bar in such a way that the marking corresponding to 60 millimeters of mercury should come in line with the index marking on the weight holder, and turn the knob to position 6. Just rotate the knob a little forwards and we can see the forward movement of the feeler arm with the tonometer head, and now when we rotate the knob a little backwards, we will see a backward movement of the feeler arm with the tonometer head. So ideally at all these 3 positions, this movement should occur within the range of 0.5 millimeters of mercury. So if we do not see this movement, then we have to send back the tonometer for recalibration. Thank you. Thank you.
It was by Dr. Mini. Yeah. So thank you. That was really nice, Dr. Mini. Yeah, very nice actually. And I think day to day you may not be doing this, but at least once in a week or once in 2 weeks, or if you suspect that there is an error, definitely you should do. And the easiest is that the first step that she said, keep it at 0, move it a little 0.5 anteriorly, see that it moves anteriorly. Then you get it back to 0, move it posteriorly, an anti-clockwise rotation. You'll see a backward movement. This should be equal. Then it is calibrated, it is good. Then you can proceed. And please, if you have multiple tonometers in your hospital, try in the same patient, in multiple patients, and see whether there is an error and that this needs to be calibrated. Otherwise, you should do a periodic calibration. Thank you. That was a nice one, actually. Basic, very important one, Dr. May. Thank you. Next, we have Madam.
Next, we have Dr. Sanjana. She is a cornea surgeon working in Agarwal's Eye Hospital, Kochi. She will be talking on the use of rust removal bar corneal foreign body removal. Over to Dr. Sanjana.
So it's a complete 4-minute video. So once that is done, we can do the discussion.
In this video today, I shall be discussing about how to remove a metallic corneal foreign body. Most of the time, these are patients who come following a welding work with complaints of pain, redness and foreign body sensation. So the first and foremost thing is to instill a Paracane eye drop so that the patient is pain free. After which, the patient has to be placed over the slit lamp for evaluation. Now the position of the patient is very important to make sure that proper evaluation is done. So once we locate the foreign body on the cornea, the work is not done. We need to look at the conjunctiva, the fornix, evert the upper lid and look at the superior upper fornix as well as the lower fornix to rule out any other foreign body. So once the clinical examination is done under diffuse illumination, fluorescein staining has to be done to identify if it's a deep foreign body, is it Cedars positive? So for a corneal foreign body removal, you need a speculum, Paracane, either a butt or a 26 gauge needle. Now normally it's difficult to hold the needle by itself, so it's always better to attach it to a syringe. Placement of speculum is very important to prevent sudden closure of eyelid or disturbance while removal of the foreign body. So once the speculum is placed, the patient is asked to look straight to a point so that there is no movement of the eye. If it's a very superficial foreign body, fresh foreign body, sometimes it can be removed just by a cotton bud. Now if this is not possible, then we need to use the 26 gauge needle. I would always advocate a minimal bending of the 26 gauge needle, as this would provide a safer method to removal of corneal foreign body and also prevent perforation. When we approach the cornea from the temporal aspect, if the needle is bent, we are placing the bevel up on the cornea. Hence, even if the patient moves, the chance of corneal perforation is minimal. Whereas, if we are going to keep the needle straight, there are high chances, as it is directed towards the anterior chamber. If there is slight movement, the cornea can get perforated. So, once the needle is bent, now we ask the patient to look straight and approach from the temporal aspect. So then with the bevel up, we need to go towards the anterior stroma and disturb the foreign body. So once the foreign body is removed, it's always very important to note the presence or absence of rustring. Rustring sometimes can be very superficial and very smooth. Thus, while removal, it may be difficult in the first sitting. In case the rustring is not removed in the primary sitting, patient has to be called back after 24 hours. Then it becomes easier to remove the rustring. Once the rustring is removed as well as the foreign body removed, patient has to be given topical cycloplegic as well as antibiotic eye drops for at least 2 to 3 days till the epithelium heals. Patient has to be informed to come back to the hospital if there is pain, discharge or decrease in vision. Some of the complications of corneal metallic foreign body are delayed presentation causing leukocytic infiltration, secondary added infection could be bacterial or fungal, or deep foreign body. Extra care has to be taken while removing a limbal foreign body, as the chances of perforation is slightly higher in these areas. And in case of perforation, a contact lens can be placed. Thank you.
Thank you.
Thank you, doctor. That was nice. And as you correctly said, when you have a foreign body in the cornea, always be prepared for a perforation.
Yes, sir.
See, even after removing, suddenly you will realize that it's actually full thickness. A small portion may be jutting into the through the endothelium into the anterior chamber. So you should be prepared. And ideally, if you have a small one, it's always better to have a glue.
Exactly.
Glue, cyanoacrylic glue, which is very cheap
And place the
actually compared to
VCL
the
on
other
top
glues
of
that are available. And a bandage contact lens. These two. And then
Mainly the positioning of the needle is very important because most of them tend to keep it straight. So that
very
is when
nice.
the
That one
chances
point
of
I'll take. That was very
perforation
nice
is important.
actually. Maybe I will also start bending needles when I take foreign bodies. Yeah, thank you so much,
Thank
doctor. Yeah, very nice. Now we have Dr. Dahlia talking to us on soft contact lens fitting. Dr. Dahlia is a senior teaching faculty at LIP Medical College.
So my topic today is soft contact lens fitting. So whenever a patient come to us for a contact lens fitting, we have to see into many factors before we order for a contact lens for the patient. So scan in the slit lamp, the patient has to be scanned throughout for any abnormalities which may hinder contact lens use. You have to scan from the temporal to the medial side. The lid has to be, whether there is any evidence of any lid abnormalities, the conjunctiva. Then you properly see a refraction, a subjective and objective refraction has to be seen for the patient. When you do a subjective and objective refraction, you can also get the keratometry values, which are important to know the total diameter of the lens. Confirm it by the objective refraction, retinoscopy has to be done. And with all this, a subjective refraction with the patient has to be done. The trial lens has to be done and see whether the patient is comfortable with the uniocularly, binocularly, and also whether the patient is comfortable for near work also. This is the subjective refraction being done with the patient. Now for the measurements which have to be made is the horizontal visible iris diameter. So which is the patient has to be in the primary gaze. This is the horizontal visible iris diameter, which is measured either with a caliper or a millimeter scale also is useful. The palpebral fissure height has to be measured. If there is an increase in the palpebral fissure height, a large contact lens has to be ordered. Horizontal visible iris diameter plus 2 millimeter will be your total diameter of the lens. Now, Schirmer test to evaluate whether there is any dry eye. T-BUT has also to be done for the patient. Now, these are the measurements. Then record all the measurements. You have the keratometry values. So, average keratometry values will help you to find out the base curve of the lens. The horizontal visible iris diameter plus 2 millimeter will be your total diameter of the lens. Palpebral fissure height, the subjective refraction. It's not working. So this is all the recordings which are to be made. Now the total diameter, all the recordings which have to be recorded for the patient. The power of the contact lens from the subjective refraction. So the spectacle power divided by minus the back vertex distance has also been checked to know the power of the contact lens. moving. Now the contact lens being placed with a trial lens, you can use this. Here the refraction of the patient was -2 diopters, but this is done with a -1 diopter contact lens. You insert the contact lens and see whether the patient is comfortable. Ask the patient to move along. See whether the patient is comfortable and look for the centration of the contact lens. So you can see the coverage of the contact lens that should be adequate all around. The movement when the patient is moving on all sides, the movement should be adequate. It should not very freely move because that will be, if it's a larger diameter lens, it might move too much. Now this is a push-up test. What you are doing, the lower edge of the contact lens is just pushed up and see whether it is freely coming back down. This has to be also to be done. When it is very freely moving, that will go off otherwise. Now this is over refraction being done because it was a trial lens with -1 diopter and the refraction was -2. If it's the same power what you are using for it, you don't have to do a over refraction, but here the over refraction is also done with the -1 contact lens and -1 is the over refraction being done. And this is the final prescription which has to go. See, there is a good centration, good coverage, the patient is comfortable, optimum movements. Since there is a little more lag, the base curve has to be increased. The final prescription should also be given to the when you are dispensing the contact lens. So accordingly, the trial what you have done, you can modify the prescriptions. If it's an optimal fit, no modification is required. Steep fit, you order for a flatter base curve, and with flat fit, a steeper base curve can also be ordered. Thank you.
Very nice, Dr. Dahlia. Yeah, soft contact lens, even though we all practice, a lot of small things I think which are very relevant. And as she rightly said, the lens should be centered well, moving when you are blinking a little. And you should also observe under the slit lamp whether any blood vessels at the limbus are being pinched by the contact lens. That is one thing. And then you check for the visual acuity. Visual acuity, you check for distance. You ask the patient to blink, and see whether the vision continues to remain stable during the blink also, after the blink. If it is not stable after the blink, it is loose. That is one thing that is one idea that you will get, and immediately you will try to change the base curve. Second thing is, whenever you do over refract, fog the other eye so that the patient doesn't accommodate. That is one. And then near vision you should always check. That is one thing I feel. Any patient you are giving, particularly for myopia, always check the near visual acuity with contact lenses. And otherwise, it was a very excellent presentation. Very useful one also for practice. And please remember to give a handout to the patient and explain to the patient how to handle soft contact lenses. 2 weeks it will take for them to learn how to handle contact lenses. They will learn insertion and removal is absolutely easy. They will learn it in 2 weeks' time. But hygiene of the contact lens is extremely important. I have seen one of my patients who was an MBBS student, long time, this was 22 years back, a Malaysian student, where came in, had severe conjunctivitis. I said, let me see your contact lens and the case. She put her hands into her jeans pocket and took out the lens, not the case. And so I think teaching the patient hygiene is absolutely important. Thank you. So who is next?
So next speaker is Dr. Jyoti Prakash. He will be speaking on basics of OCT. As you know, OCT is the mainstay in the treatment of retina, and the basics are very, very important, especially for the beginners. Over to Dr. Jyoti.
Thank you, ma'am, and thank you, KSOS, for the opportunity. I'll be talking about basics of OCT. The basic principle, if you look at from the postgraduate's point of view, this has been done to death. This photograph has been there around for almost like 20 years, and nobody understands what it means. But everybody mugs it just for the heck of it. Similarly, that was the time domain, this is the spectral domain. It is just a difference in the light which is used. Coming to the retinal anatomy and the macula, as you look at it, it is all the 10 layers. And if you go into the morphometric analysis of it, keeping the two slides side by side, you can see actually how well spectral domain OCT depicts the histopathological structure of the macula. Reporting an OCT scan is very important. Just writing the diagnosis doesn't make you a good clinician. You have to be very precise with the way you interpret and you depict the findings. It is always mentioned in the sense of reflectivity. It can be a hyperreflectivity or hyporeflectivity. It could be of the layer or the dots or the membrane structure which is seen. It can have cystic or cystoid spaces and shadowing. Going just from the basic theory part of it, going to the examples, vitreomacular surface abnormalities, first of all, would include one of the photographs I've taken up from the article, which shows the various stages of the epiretinal membrane. From top, you can see it's the stage 1 epiretinal membrane, in which the foveal contour is very normal, and the layers are retinal layers are all intact in the normal, almost normal architecture. Apart from the hyperreflective membrane which is seen on the top of the retinal surface, you don't see any other abnormality. In stage 2, you can see an inversion of the foveal depression along with the presence of the epiretinal membrane. In the third stage, you see that the foveal pit is almost absent and there is a presence of ectopic inner foveal layers. And stage 4 is when actually the severe level of metamorphopsia tends to develop in. Along with the ERM epiretinal membrane, you can see the disrupted retinal layers and the other stages, features which are present in the previous stages. Focal vitreomacular traction. Now this is when the PVD is induced at the other places but is attached at the foveal center. That is when you can see an attachment of the vitreous to the top of the foveal depression, and it causes a cystic change in the inner layers of the retina. As it progresses, it becomes slightly more severe, and this is how the picture looks. Looking at vitreomacular adhesion, if it is not pulling it, it is just attached to it, and it is called vitreomacular adhesion. When it progressive, it causes the pseudocyst, and as it keeps on progressing, it leads to a full thickness macular hole with the vitreous being attached to the operculum. And in the full thickness macular hole, the operculum gets detached, and you get a full thickness macular hole in the underlying area. This has to be contrasted with an lamellar macular hole, which is usually seen in epiretinal membranes. And the difference between the two happens to be that if you look in the full thickness macular hole, there is a total absence of retinal layers in the center. Whereas in a lamellar macular hole, it is only the inner retinal layers which are involved. If you look beyond in the subfoveal look, in the lower part of your scan, you can see the intact external limiting membrane, the RPE, the interdigitation zone, and that entire complex is intact. So the visual acuity won't be as affected as you would see in a full thickness macular hole. Intraretinal and subretinal pathologies, the most common one being diabetic macular edema. If you look at it, the first thing which we see here is a gross edema of the retina. It is called spongiform macular edema, in addition to multiple hyporeflective areas which are seen within the retinal space along with hyperreflective dots, and a subretinal hyporeflective area which depicts the serous macular detachment. This is a case of central retinal vein occlusion, in which you can see the massive cystoid macular edema. Branch retinal vein occlusion having a similar picture along with a serous macular detachment. Here the contrasting picture is that the area which is not affected has a normal profile, whereas the area where the occlusion is there, you see an edematous retina. Drusen or drusens, how is it called? These are actually excrescences which are seen in the RPE. It's actually drusen. Drus is the singular word, drusen is the plural. PCV. Now PCV, as we all know, is the diagnostic modality of test happens to be ICG angiogram, but is it possible to diagnose PCV on a case, on an OCT? So it has been shown in literature that peaked PED, a thumb-shaped PED, a notched PED, and the presence of a DLS or also known as the double layer sign, and SIRE as was labeled by Bailey Freund, it's called a shallow irregular RPE elevation. These are features which would direct you towards the presence of a PCV underlying. This is a macular neovascularization. You can see intraretinal edema, subretinal edema, you can see subretinal hyperreflective material, the presence of backscattering from the fibrovascular PED, and if you notice very carefully, you can see a compacted choroidal layer rather than the pachychoroid which is seen in cases of PCV. This is, I'm just taking a few more seconds. This is very recent addition to the vocabulary. It is called ORT, the outer retinal tubulation. This is generally seen in last stage of macular neovascularization along with scarred scarred AMD. This is just to show the dramatic effect diabetic retinopathy has in the final stages. It's a tractional retinal detachment. To one side of your screen, you can see a serous detachment, a tractional detachment along with a drill in the central layers, that is a disorganization of inner layers along with a schitic change in the temporal part. A CSR, this is how it looks. Isolated serous PED and serous fluid pockets in VKH. Did we come back to it or did we see upside down? Look long enough into the OCT, you will actually fall in love with it. Thank you very much for your kind attention.
Thank you, Dr. Jyoti, for that wonderful presentation. Next, I invite Dr. Indu for intravitreal injection technique. She is a consultant, vitreoretinal consultant at Chaitanya Eye Hospital, Kottayam.
Good evening, everyone. I thank Dr. Dalia for this opportunity. So we go to the topic proper, intravitreal injections. Now, in pre-injection protocol, what I follow is an informed consent is necessary. Pre-injection antibiotics are controversial. You may give, you may not give. It's personal choice. You have, prior to giving an injection, always check for signs of infection or inflammation in the eye or adnexa. Review the patient's file, OCT, and fluoresceint angiography, whatever is available. And always, always, always do an indirect ophthalmoscopy prior to injecting. Confirm the eye that has to be injected and mark on the OT list. Now coming to the injection protocol that I follow. So the first is about preparation of injection. So as you can see here, I'm fully scrubbed. I have put on the surgical gown. I'm keeping everything ready. So the sister hands over the syringe. And this is the filter needle that is used to withdraw the injection from the vial. And this is the 30 gauge half-inch needle that we normally use for injecting. It's a very small needle and it reduces the vitreous reflex. So I have kept everything ready on the tray. Now the sister puts a little bit of spirit on a cotton bud, and this is mainly to sterilize the top of the vial prior to withdrawing it from it, withdrawing the injection. Now the sister brings in the injection. When very carefully she removes the top plastic cover without touching the inside part. I now sterilize it with a little bit of spirit, the top of the vial, and then bring in a fresh bud and remove the spirit. Now very carefully, I put on the filter needle. This is a filter needle that is used for withdrawing the injection, and carefully remove the cap so that you don't touch anywhere. The tip of the needle does not touch anywhere. And very, very carefully pierce the center part of the rubber cork and push it down. And as you can see, the sister is slightly tilting the vial so that I can withdraw the injection fully. So I have withdrawn the injection now, and after I withdraw it, I catch hold of the filter needle and pull it out and make it upside down. And at this point, I slightly withdraw the piston a little more so that whatever injection is there in the filter needle also comes into the syringe. Now dispose of the filter needle and you place the 30 gauge syringe. I hold the syringe at my eye level so that I do not mistake air columns and fluid columns. Give it a tap to remove the air columns, and then slowly push and pull so that the entire air inside is removed. And in between, I keep pressing the 30 gauge needle so that sometimes it becomes loose and it falls off. So and then slowly inject it and make it into the desired quantity of 0.05 ml. So now the injection is ready. And I place it on the tray. Okay. Now, the patient is brought in. I confirm with the patient which eye is to be injected. As you can see, he had pointed to his left eye. Now, the sister puts a drop of paracaine, followed by a drop of povidone and give it a contact period of 2 minutes. So once everything is ready, scrubbing is done. The draping is done. Place a speculum. And once a speculum is placed, the sister gives a thorough wash to remove the excess of betadine. The surgeon comes in. I anesthetized with a drop of paracaine. A caliper is taken in and the measurement is taken, which is normally 3.5 millimeter for pseudophakic and 4 millimeter for phakic patients. Sister hands over the needle. The injection is given with a steady push of the plunger. And then removed and handed over. And immediately I place a small cotton bud to reduce the vitreous reflex. And soon after giving the injection, always check the fundus. You have to check whether there are arterial pulsations, and if you see arterial pulsation, it indicates a raised IOP, and always do a paracentesis. So this is a close-up video. So anesthetized, the eye has been anesthetized. The caliper marking is made. The surgeon brings in the needle, and the direction of needle, as you can see here, is pointed towards the center of the globe. It is injected fully, and with a slow push of the plunger, you can see the injection going into the vitreous. And after the entire injection has been injected, you pull it out, and while you pull, you press either with a forceps like this or with a bud. And in the post-operative period, I normally instruct my patients to remove bandage after 4 hours and to avoid head bath for 3 to 5 days. Most of the patients, I have a repeat indirect ophthalmoscopy at 3 days, and if everything is okay, I call them back at 1 month. But however, patients are always instructed to review in case of any kind of discomfort they have. Thank you.
It's a very lucid, very nice description of a procedure, which I have not seen many because I'm not a retinal surgeon. Very nice. Long time we always used to give intravitreal for endophthalmitis. Never like this. Very nice actually. And what about post-op antibiotics? Do you give? Or is it just betadine? And
Personally, I always give antibiotics in our hospital, but there are people who don't give also, but it's your personal choice. Giving an antibiotic post-operative is always safer, legally also.
Yeah, medical legally it is important. Even betadine is the most important point. Yesterday there was a medical legal discussion where Dr. Ashok was talking about a case where the doctor was punished because he did not use betadine, or rather he did not have a record saying that he has used betadine before giving the injection, and the patient had inflammation.
Normally we don't record that, but
you have to record.
Yeah,
that is
yes.
what I think.
Yes, you can just mention betadine. The eye was scrubbed. The eye was cleaned with betadine.
Excellent.
So that mentions it.
Thank you. Thank you.
So next we call Dr. J.K. Reddy, who needs no introduction in KSOS. The use of diamond bar, managing recurrent erosions and pterygium.
Good afternoon. This is a good old instrument, but somehow is not much used in ophthalmic practice. It's very useful. Even I didn't use it for the past, maybe I'm practicing for 30-40 years, 35 years. So I never used it. Now I started using for the past 10 years. It's an excellent instrument. So I want to popularize. Yes, okay. Yeah. Some version problem. So the diamond bar used in ophthalmology, I suggest everybody who enters ophthalmology buy one bar. This only just costs 10,000 rupees. It's a wonderful instrument. and it makes wonders. So this is a simple one. You got a motor, you got a battery, everything in this, and you got a tips. And the tips are, there are two tips. So the R means rough, F means fine. That's all. This is a diamond. The small ones, 1 millimeter is not diamond. 1 millimeter, 0.5 millimeter is a carbide tip. So, but still you can say diamond. Diamond is always, diamonds are forever. It's very interesting. I had 10 diamond knives in my early cataract surgery. Still I'm having them. So I like diamonds. They're forever. So this they give a small thing like this. From this you have to choose it. Choose 2 millimeters F. That means fine. You don't need a rough one. Rough one is rarely used. When you are buying that, you buy that with the one. You can buy even 2 or 3. Each one they charge around 4,000 rupees. So this is the video showing how you this one. This is the one, and you unscrew it. You got a battery. You have to know this. You have to battery because during COVID times. We never visited hospital for 1 year. They kept it like that. The battery. I lost 2 diamond bars. All became battery leaked and motors are all gone. I had to buy a new one. So when you are not using for a few months, for example, you go on a long trip, something like that, remove the battery and keep it. If you leave the battery, it will drain and you will lose the. It's only 5,000, 6,000. It's not a big money, but still it's a waste. So this when you turn fully, it will rotate. When you a little bit unscrew it, it will stop rotating. That's the contact time. So teresium, this is a teresium. You see that is coming to the pupil area, and you try to cut with the blade. It's gone. It's gone. The anti-surface of it's not the clean cornea that is important. It is the surface quality of the cornea that is important for vision. It's not the clean looking cornea like a glass. Even in that surface quality. So you just peel off teresium, whatever left tissue, you can nicely use the diamond bar even in the pupil area and make it very smooth. You get a very nice post-operative vision after cataract surgery. Wait for 6 weeks. Even with the teresium onto the pupil covering entire thing, you get excellent results if used. I recommend every case of teresium use diamond bar. Don't do any teresium without diamond. And patient also likes it. You say I am using diamond bar in you can charge few thousand extra. There will be diamond means this always a value. A little bit opacity, the corneal opacity, don't worry about that. You get a very nice surface. Then RC, this is a beautiful one. You need to recognize where the RC is. See in slit lamp examination. And OCT, they say you can see RC, but we find very difficult to see it. So you see slit lamp examination, you can see RCE where it is. And it's a very simple thing for ophthalmologists, for very distressing for the patient point of view. For example, this patient is a bit complicated one, right involving the pupillary area, and it's a post-LASIK case. She got operated for LASIK for marriage, and she has to postpone her marriage because she is not able to open her eyes. So after 3 months she came to us. There are microfolds, everything it will disappear. You can see the LASIK flop here. Nothing, no need to worry at all, absolutely. You can do with the diamond bar even up to the periphery, which you cannot do with excimer laser. Excimer laser you can do only 8 millimeters. You cannot do for 11 millimeters. In diamond bar up to limbus you can polish it and they do very well. For example, you can see the flop. She is doing exceeding well. After 1 month she got married. So sometimes just empty your mind. Don't think about anything. You find the patient, you see how you can help the patient and think about it and find your own way. Thank you very much.
Thank you, sir. I have one doubt. How will you sterilize this diamond bar?
Yes, because a small talk I didn't give it. The first one is you have to you cannot sterilize it. You can sterilize by using EVO gas, the diamond bar, the main unit with the battery all, but it's not necessary. You can just use alcohol. That's we call it disinfection. We don't call it sterilization. Alcohol and wipe it off once or twice, 2 times. And the tips can be autoclaved. The tips you can autoclave and pack it and put it in the tip. This is not called sterilization. This disinfection, sterilization, both combined use.
Okay, any doubt since sir is leaving? Any doubt you can ask now. Okay, thank you, sir.
And next speaker is Dr. Kavita. She'll enlighten us on cover, uncover test. Now, this is one test in screen which I always forget. So I always love to listen, actually. And squint is something that is beyond me. So
I thank KSOS for this opportunity. Just the first slide is on the prerequisites for cover uncover test. I just made a mnemonic like A, B, C, D. The patient should be able to understand what you're going to do and be attentive, be cooperative, and able to fix at a target both distance and near. And there should be good extraocular movements which should be full. And the equipment is very simple. We need a torchlight, occluder, both dark and translucent, which is called the Spillman occluder, which comes in combination. Now, earlier we used to get it as a single one. And a target could be a Snellen chart and a near chart, or some kind of a toy which is attractive to the child. And prism bar and loose prisms. In this test, one thing we have to remember is cover test is to understand the other eye which is uncovered, what is happening to that. So first is whether there is a refixation movement. Second, if the direction of the refixation movement and how fast it is refixating. So likewise, cover, uncover, we will look at the eye which is under the cover and what exactly is happening. And again, refixation movement after you remove the cover under the eye that is under cover, and the direction and the speed at which it is moving. And then the third thing is alternate cover test. So in the first two, we are looking at manifest deviation, and the second is alternate cover test. Actually, we are breaking down the fusion. Therefore, you are eliciting latent deviation along with manifest deviation. You will get the total deviation. Sometimes the eyes may look straight, but then you do alternate cover test. You pick up the phoreas. So that is latent deviation. So in all this video, I won't be explaining repeatedly because of lack of time. So now in this child, the eye appears that there is left eye squint. So I'm doing alternate cover test, but there's no particular refixation movement in either eye. So this is the first thing that we have to rule out is pseudostrabismus. Likewise in this child, the eyes are appearing straight, but now I'll do cover the right eye. There's no deviation in left eye, but there is deviation in the right eye. There's a refixation movement. So when you do alternate cover test, there's repeated refixation movement. So this is phoria. In this boy, there is esotropia. Eye is already turned in. Now you do alternate cover test. And keep examining. There's an outward deviation and each eye is fixating relatively okay. But there's relative dominance of the right eye because left eye is taking up fixation at a slower speed. So all the tests are done for distance as well as near target. I'm using a near target here. Now the first thing how to neutralize is I use a bar to neutralize, but this comes only about 35 prisms. So I use 2 loose prisms to understand where exactly it's getting neutralized or there is no refixation movement. So I'm using 2 loose prisms. It's slightly difficult, but then you can get this perfect position of the prisms by practice. Distance and near it is measured. So the esotropia is getting neutralized at 75 prisms. Now with the glasses, if the patient is wearing, this test is done once again for distance and near. And it's getting neutralized at a lesser prisms, that is about 45. So there's a difference of 30 prisms, which is covered up by the spectacles that I have given. What is this now? Patient is wearing specs, but there is a movement in the opposite direction. So this is 55 prisms, so it's over, So this is another patient with esotropia. She wears glasses and it appears as if the eyes are straight. It doesn't end here. You do alternate cover test and you see that the right eye is deviating out. So there is some residual squint or esotropia. This is partially accommodative esotropia. I think this is Yet another one which I want to show is what really is happening in the left eye is this minimal nystagmus, and after doing alternate cover test, there's exaggerated nystagmus. So there is manifest as well as latent nystagmus, and also you can appreciate that there is slight poor fixation movement in the right eye, which indicates there is lesser vision as compared to, okay, this video you can see that right eye is deviating, moving down, that is DVD. This is the last. You can see that the right eye is coming down and alternatively the left eye is moving up. So this is alternate hypertropia, which you can see that it's slightly lesser in the right gaze. Now I am changing to left side and it is slightly increased on the left gaze. This is the Park 3-step test for hypertropia. And then you do the third step is the tilt, where you can see that obviously the right hypertropia is increased much more than in the gazes. So we can see, these are the birds in my house. I just picked up this video where there's these feeding alternatively, something like our alternate cover test. Thank you.
Thank you so much, madam, for that
Thank you.
excellent video presentation, clearly demonstrating each. I always have a difficulty when there is both horizontal and vertical squint altogether, when utilizing with the prisms, how to go about with that.
Yeah, you keep the horizontal, loose prisms will be better then. You need an assistant as well to hold the position of the head and make sure that the patient is resting well at the back. So invariably they lift and then the position is not at primary position. Of course, all these are done in all the 9 gazes. You keep the loose prisms behind the vertical component depending on the direction. If there is hypertropia, you use roughly about 10 to 12 prisms. That is the routine prism diopters that we encounter. So you keep it behind the horizontally placed loose prism. Then hold it together and then you can do the alternate cover test.
Okay.
That's it.
Thank you.
Thank you.
And madam is a senior pediatric consultant at Changara Eye Hospital, Shimoga. Next, so the last talk will be by Dr. Lima on protecting your back ergonomics in OT and OPD. Lima is assistant professor in Government Medical College, Alpura.
Good evening, everybody. Basically, very recently we had a wake-up call. One of our colleagues had a shoulder pain and then which developed into a numbness. And she was like, if you take the whole team of Alapura, she was younger than at least half of us. And then the whole thing unraveled and she had a problem with the neck and the spine and stuff like that. And then we immediately realized, oh my God, this is happening. And then most of the changes were permanent. Nothing is going to change. So we realized that we really need to protect our back, our spine and all that during this thing. So ergonomics is designing your space in such a way that human efficiency is brought about. So medical professions, as you know, especially ophthalmologists, have a high risk of musculoskeletal disorders. We have disabling back pains, neck pains, numbness in extremities. And the problem is it's all in a day's work. We're just doing a routine and you're having a problem. And it is chronic in evolution. And the moment you have the signs and you consult a doctor, it is permanent. Some of it is permanent. You might reduce a pain, but the changes that has happened in your spine is permanent. So that is something like we really need to look into it. A survey, we have lots of studies now on this, and we've realized that almost 50 to 75% of ophthalmologists are having some kind of musculoskeletal disorders, and vitreoretinal surgeons, as you can guess, has the maximum out of it. Now, what are the risk factors? So the risk factors is we're doing repetitive works under stressful circumstances, and there is a fine motor control. There is a lot of things. There's computer keypads now with EMRs coming in. So prolonged maintenance of awkward body positions, all those things becomes your risk factors. So the American Academy of Ophthalmology has a task force, and I've used their guidelines to give you these videos. So in slit lamp examination, of course, it's very important to have adjustable chairs for both the patient and you so that you can work in a good thing, so that you should be very careful that your neck is not flexed or extended. It should be straight. So that is the kind of examination. Another thing that we always do is sometimes you make because you want to cater to the patient, you make the slit lamp closer to the patient, you bend down to see. Instead, you ask the patient to come closer and you examine like that. And as you must have seen, the JR was not all the time bending towards. So they say a custom-made slit lamp with a smaller piece will give you a more access to your eyepiece, and you don't have to bend towards a patient. This bending also happens when you examine, when you kind of explains to the patient. The patient does not understand. You have a habit of bending towards them so that they understand what you're trying to say. Don't do it. Keep yourself erective in that time. That care shown to the patient might be not a care to your spine. Now, coming to indirect ophthalmoscopy, again, a standing position will give you a hyperextension of the wrist. Then your back is going to be awkward. You have lateral turning of the spine. Don't do it. Make the patient lie down. Make the patient lie down, and the examination should be done there. And you have, if you can, you sit and do the indirect ophthalmoscopy, keeping yourself erect. Learn it. It might be a better for your spine and neck. Now, computers give you a lot of awkward positions. Sometimes if you're tall, your leg doesn't go under the console. So you have to make sure that the monitor should be down. You should have an armrest. Don't sit on chairs without armrest. And there should be good back support. And now coming to the operate microscope, set your seat height in such a way that your feet is on the ground. You should never have it hanging down, And the second one is, while you do the table adjustment, if you do like this, you find yourself bending over to do the patient. Instead, your first adjustment should be your seat. Your seat should be comfortable. Then you adjust your microscope. And then you make the table height to your desired thing so that you don't hunch down to do the surgery. Now, next one is your foot pedals have to be should not be away from you, because that will create a lot of problems. It should be very close to you so that your legs are not hyperextended or anything while you're using the slit. Then, here you can see you're struggling with this thing. You should not struggle. The knob should be loose enough that you can move it during the surgery. And in microscopes that can tilt the eyepiece in such a way that you can see it properly. Now, you can have 3D glasses, and you can practice doing it on the monitor, especially for the vitreoretinal surgeons, to maintain that. Other points is contact stress, like your elbow is on the table, so you can have padded places to keep it. Breaks in between, every 20 minutes, take a walk, and maybe even do prophylactic neck exercises during that. And one thing is, since we are really promoting the industry, we can say that one size doesn't fit all. We have tall ophthalmologists, we have short ones. We can have different types of instruments for us. They don't have to give you one slit lamp and then we have to adjust it. We can tell them that we need different designs, depending on you. Thank you so much.
Thank you, Dr. Lima. Any suggestion from JP sir? He is a very excellent ergonomics.
No, it's practically I have a lot of ergonomic problems. So that way I am experienced. I do get neck pain and back pain when I sit and operate for long hours. So what I do is between two surgeries, between two tables, I will walk. Actually, I do walk. I get about 4 feet in my theater to walk. So I continuously walk in the break between the two surgeries. And I'll do my neck exercise, flex and all. I have kept music in the theater. And another problem other than musculoskeletal are your eyes actually. Dry eye is an issue that I have found, because you are sitting there continuously throughout the day, staring down the microscope without blinking, because when you are doing anything with concentration, your blink rate comes down from 15 to 20 to 2 or 3 times a minute. So that creates an issue for your eyes. And then you are in between, whenever you get little time, you take your mobile and you will be going through WhatsApp or maybe texting and all. And then once you come home, once again you are on your WhatsApp. You are in multiple me group or I group, I do not know, but which multiple groups are there. And then you sit late in the night. I sit and read in the night actually. And then I see a movie. So sleep at 12 o'clock, 1 o'clock. That means the entire day your eyes are exposed and are dry. So this is one thing. You have to do exercise like what you tell your computer vision syndrome patients. Practice them also, and take care of your back and neck too. Thank you. It was a wonderful IC. Dr. Dahlia, thank you so much for inviting me. Thank you so much.
Thanks so much for moderating the session also. It was happy to have you, sir. The certificates, Dr. Lima Dr. Bindu and Dr. Bindu for joining us on stage. Dr. Mini. Can we, all the available speakers, have a photo session? Sir, can we have a photo also?